because I was born 15 kilometers from here. So we are going to present quite a peculiar situation, but a very topical one, and having to do with endothelial plastic surgery, and which is typically of the American continent. So a 69-year-old woman with Fuchs dystrophy, cataract, good state of health with an osmotic agent. So a visual deficit caused partially by the guttata and the edema, but also by the presence of a cataract. So the situation didn't seem really complicated. So DMEC was proposed with an IOL implantation. It was done in 2016. Okay, but then after 1 week from the surgery, this is the picture. If you take a closer look, you see that there are very little point-like opacities at the interface, 4 of them to be precise. So at this point we wondered, what is it? What could it be? Could they be residues of viscoelastic that have been trapped at the interface? Could they be foci of epithelial ingrowth or inflammation of the interface? Could it be an infection? What? What do you think? A few more seconds. Okay. Varying opinions. It might be an infection, might even be debris at the interface. I resolved the question for you. This is what the culture of the storing medium in which we had stored the cornea told us after a few days. It was a sort of candida, so we don't know exactly which one, but at this point we panicked. What are we going to do at this point? We might decide to perform no treatment or antifungal topical treatment or topical plus oral treatment, or should we think of a surgery and remove the implanted flap and see what happens? What do you think? Let's have the answers. Okay. Topical plus oral with antifungal drugs seems to be the prevailing approach, and this is exactly what we have done. So we've used amphotericin B 6 times a day, 15%, and then voriconazole twice a day per os, and then we've also tapered quite rapidly the topical steroids. This is something that we do not routinely do when we perform a DMEC, but here the discontinuation of the steroids we thought might bring about or cause the infection to become overt, and so allowing us to make a better decision after all. And this is the situation after 2 months from the DMEC. No symptoms, uncorrected visual acuity 10/10, but the point-like structures did not disappear. So at this point, I actually left the situation as it was because I had to leave. But what happened 1 year, more than 1 year after surgery, regardless of possible other topical treatment, the infection had a new flare-up, and so this is a crystalline lens at the interface, you may see, and then it becomes an overt infection with hypopyon and pus at the interface. So what can we do now? Should we restart ampho-B or add maybe another topical antifungal like natamycin or intrastromal ampho-B? So antifungals, or should we think of an endothelial therapeutic surgery or even a therapeutic or penetrating procedure? What do you think?
Vediamo che insomma
As you may see, the surgical approach is the one that received more votes, but a more cautious approach, i.e. medical treatment, was also opted for. So our colleagues decided to have a topical IFB and then intrastromal voriconazole injections. So the clinical picture didn't modify significantly. There was even a worsening 1 month after the infection, and at this point the medical treatment wasn't an advisable option. So therapeutic keratoplasty was opted for, and the infection was resolved, but the patient had really an infinite number of discomforting situations. So fungal keratitis following a keratoplasty, but we see that 2%, in 2% of the cases there is a fungal growth, and 2% of them have an infection. This is due probably to the fact that the cornea is processed in a high bank, or it is exposed to room temperature. This is mainly yeasts, and or it was. They were yeast in this case. Infection actually set on 2 or 3 months after surgery, and this is due to the fact that antifungal agents that are big molecules cannot penetrate the interface. So the therapy which seems to be most effective in these cases that are mostly caused by Candida is intrastromal amphoby, as it has been shown in the literature. So what's the take-home message? First of all, this is an atypical case because the clinical presentation occurred several months after surgery. What could we have done differently? So intrastromal or intracameral better, amphoby, because intrastromal forms a depot in the cornea, and immediately or at reactivation. Or we might have considered an excision of a key graft plus redo EK, maybe even lately. So there are open questions that I actually address to the panel and the audience, but in case there are no clinical features, so here the patient has no clinical manifestations, what would you suggest to do? To discontinue steroids after surgery? And then there is the question of the difference between Optisol, which is used in North America, and the organ culture, which is most used in Europe, which one of the two preservation methods can be considered best. So is enough to add amphoby to Optisol in order to resolve the problem? These are still open questions.